Hello, I'm going to be talking about my experience with the Care Homes project, trying to reduce infections, as we said. So it was a one-year project, and the aim of my project was very simple. It was to reduce the number of CDI and MRSA infections in care homes. And there were a total of 114 care homes in the area. My brief wasn't just limited to public sector care homes. I also went into private care homes as well. So my first job was to see what sort of a problem we had. We knew there was a problem in care homes, but there wasn't any proper system of surveillance in place at the time. So we didn't really know how big the problem was, which meant we couldn't see if the project had actually been successful to reduce infections. The first thing to do was to create a directory of care home addresses and postcodes and compared them to the previous year's lab results. And that gave an indication of which postcodes had infections, and then we could look into those further and see if they were actually patients at the care home with the postcode. Then, going forward from that, any new lab result that came in, I would check the postcode on the lab form with my directory to see if it was a patient in that care home. Because what we found was that a lot of the GPs would just write the address of the care home rather than stating it was a care home, so it might be 15 Green Lane or something, or would actually sometimes even just give the GP surgery postcode. So it's actually quite hard to get an idea of the extent of the problem. When results were found that were positives, they were followed up with the homes, because another problem that we'd identified was that sometimes the GPs would take a while to get in touch with the home to tell them that their patient had an infection. So you could have a patient with who is MRSA positive, and the staff at the care home didn't know for a week, sometimes 2 weeks. So I would phone the care home and make sure that they knew what was going on, discuss with them what procedures they had in place, what they were going to do if anything needed to be done, and to let them know that there was a resource they could call upon if there was a problem. Going forward from that, it was apparent that some homes were more of a high priority than others. These tended to be the larger homes, and often it was because they would be taking people more from the acute sector, so they were having higher positives. And some homes seem to have an awful lot of patients attending A&E with infections, often catheter-related infections. They as well were made high-priority homes, although that wasn't necessarily to do with MRSA. So the first thing then, once we'd identified the homes, was to approach the high-priority homes and offer them training. And the training offered them basic infection control training, hand hygiene, essential steps, and then we offered them a customised package of training, whatever was suitable to their needs. If they had patients with PEG feeds, I'd do a session on enteral feeding. If they had residents with catheters, I'd do catheter care, and so on. And the training was offered at the care home at a time to suit the home, because that way it was much easier to get bigger groups. So, for example, I could do it before and after a shift changeover, do 2 sessions in one day, and get all the staff that were on. I also did quite a bit of evening training as well. That sort of evening shift, night swap over seemed to be a really good time to do it for the homes. Another area where we felt that training was lacking was with agency staff. A lot of the care homes rely quite heavily on agency staff, and although some of the agencies said that they provided basic infection control training for the agency staff, in practice it was virtually non-existent. So when a care home was having their training, not only were the care home staff invited, but any agency staff that they regularly used were also invited to attend, as was anyone with any relationship with the care home. So the gardener, the handyman, the person who drove the transport, they were all welcome to attend too. And we also ran some specific sessions just for agency staff. So all the care agencies in the area were sent a letter of invitation offering them free training to their staff at a series of open events, and they were very well attended. We offered homes audits using the tool that we use locally by the Health Protection Agency. We looked at the environment, the kitchen, linen, sharps, waste management, hand hygiene and personal protective equipment. And that was really quite a useful tool for homes, particularly those homes who felt that their infection control was under control and that they didn't really have a problem. By doing the audits with the staff concerned, it was apparent that there were quite a few problems going on that they hadn't noticed. And this is just some of the common problems that we found on audit. And although they relate to care to homes, actually they're pretty much the same across the board wherever you go. MRSA positive residents, staff didn't really know what to do with them, and some residents were actually still being barrier nursed in their rooms and not really encouraged to come out of their room, which is a bit of a worry. Toilet brushes. Check your loo brushes when you get back to work. I saw some shockers. They were dreadful, virtually bald. And it's something that nobody really takes responsibility for or thinks to look at. You know, the cleaners see they're getting a bit threadbare, but they don't necessarily do something about it. Lime scale, loads of lovely clean sparkly white loos, but lime scale all over the place. Light switches were a problem, people didn't seem to clean them, and particular the light pull cords. They were usually very, very grubby, especially in the bathrooms, because you can imagine people just pull them by the cord often rather than the actual end, and they were very grim. We got around that one by suggesting that they get new cords and then put some very fine aquarium plastic tubing over them, and then they can just wipe them down. Because I know there are wipe cleanable light cords available, but they were actually very hard for the care homes to source themselves. Door closure devices, they were a real nightmare. You know, the sort of metal thingies at the top of the door that close the door automatically. Because they have grease there, that attracts the dirt and dust, and they were always absolutely filthy. And I think that follows with the next point as well, which is above eye level. People are quite good at cleaning what they can see and below, but cleaning above it often gets missed. And I would find some really big cobwebs because people just didn't look up. Kitchens, always an interesting one, because if you spoke to the kitchen staff, they always swear blind that they have very high standards. The environmental health people think they're wonderful and gave them 1 million stars and they'll find nothing wrong in their kitchen. Well, a load of them had nail brushes, and prizing a nail brush off a chef is a really hard thing to do, I can tell you. Floors were often really grimy in places that, you know, weren't obvious. You had to kind of look underneath. Dates on foods in fridges, that was another shocker. A lot of them had dates of when the food was due to be eaten by, but that date had often passed. And particularly in care homes which were larger, where they stockpiled a load of food, you would often find stuff that was actually out of date. Sharps seem to be another problem, particularly resheathing of needles. And I would go into a care home or a nursing home in particular and say, what about resheathing needles then? And they'd say, we never resheath needles. And I'd say, okay, show me your sharps bin. And I'd peep in very carefully, and I could guarantee I would find resheath needles. Why that is, I don't know, unless it's because a lot of the nurses that work in care homes tend to be of a similar vintage to myself. And when I was training, resheathing needles was what you did. It was what you were taught to do. And I think getting the message out there that we don't resheath needles is going to be quite a long process. Hardly anyone had filled in the labels on their sharps bins, and I know that's just not care homes that happens in. And the temporary closure device, again, never ever used. And I think if you do spot checks on your areas, you might well find that those are problems for you guys as well.